As shall we start?
Good morning, everyone. And on behalf of Pediatric Academy of Telangana State, we welcome you all for the webinar series on clinical genetics. We look forward to this on the first Sunday of every month, and we've successfully done it for the past 7 months. And today is the 8th such episode. And we're very excited to take this forward. And I now request Dr. Sankoch Bhaskar, President PATS, to please give his inaugural remarks.
Thank you, Dr. Sri Krishna. Good morning and welcome you all. And my best wishes to our distinguished guest of honor for this webinar on clinical genetics, Dr. Neelam Mohan, our President, National IAP 2026. Thank you, ma'am, for sparing your precious time, early hours of Sunday. And in my opening remarks itself, unless I say a few words about Dr. Prajna Rangana, I will not be comfortable because she is the backbone of this entire webinar. She prepared this 1 year ago, the entire 12 episodes, the topics, and even we are thankful to her because she's getting luminaries in the field of medical genetics from across the nation. And already we had, with this, we'll be completing 2/3 of our webinars, and another 4 webinars are, after this, another 3 webinars will be left. And many of my colleagues, they were appreciating it and they called me saying, thank you, Dr. Bhaskar. This genetics, which is a little away from us, we are not having much interest. But with these webinars, at least they are getting sensitized, they're developing some interest towards genetics. They are realizing the importance of genetics in our day-to-day practice. So last time, the interesting part of our episodes is, if somebody missed the last episode, Dr. Prajna Ranganath is covering it very briefly in a recap of the last session. And last time, it was really very interesting. Many people participated like this time. Since it was about next generation sequencing, the presentation by Dr. Ashwin Dalal was so crispy, simple, comprehensive, understandable to all the pediatricians and the participants, particularly about this exome sequencing and genome sequencing with case presentations, case scenario based presentation. And this time the IEM is very, very useful for our practicing pediatricians. Whenever we do not understand anything, we come down to IEMs, particularly children having fevers or some developmental issues, and so on and so forth. So, with these few words, I once again thank you all for participating and encouraging us. This time I could see even seniors like Dr. Ramesh Srinivasan with us. Thank you, Dr. Ramesh Srinivasan. And thank you all. Now, I request our guest of honor, Dr. Neelam Mohan, to make inaugural remarks about our efforts in getting these episodes of webinar on clinical genetics. Over to you, Dr. Neelam, madam. Unmute, madam. Please unmute, madam.
Thank you so much, Sankoch. It's indeed a pleasure to be here this morning. And what I'm feeling bad is why I didn't attend all the ones every Sunday of the month. Sadly, last Sunday I was in a flight and had to miss this. But I would definitely go on your Zoom links and request you all to share the Zoom link of the previous episode, because a big hearty congratulations to Sankoch and his efficient team when it comes to Sridhar as the secretary and Sai. We have seen them performing very well. And it's so lovely to see that there is a complete scientific convener in this Pranjna. And all of you all are doing a stupendous job. And as highlighted earlier, that genetics is something which most of the pediatricians have been away. And this field, in fact, did not pick up so much as it needed to globally with the amount of population that we have, you know, with compared to the 40,000 million, 40 million children that we have. If you look at the clinical genetics that we have in India, they used to be in numbers in our hand. But it's very nice to see that there are centers who have now started training, because who doesn't know Nirja now? And I got trained in AIMS in my pediatric gastroenterology before I went to UK for my higher training, because in those days liver transplant didn't exist in India. And at that time, Madhulika was in AIMS, and there were very few people, Dr. I.C. Verma and Gangaram, where I eventually joined, and Madhulika. So these people were the ones who was doing, and it used to be quite difficult for people to travel across and to come to the city, and these tests were not there. I would really like to congratulate the pioneers like Dr. I.C. Verma and Madhu, who ensured that these tests were made available. At least when I saw how a simple TMS and GCMS and all, it used to be a nightmare then. And then eventually came an era in India. And if I may take the name, I think it was Lal Central Path, because I remember going and connecting to the boss, Mr. Lal, once, and we were all saying that why these tests are not available. I mean, his vision, he imagined, and then the number of centers it grew into, it became so easy for most of the Indians across the country to be able to do these tests and go for it. So I saw the journey of genetics in the last 2.5 decades or 2 decades. And to all of you all, if you wouldn't have seen me today as a pediatric liver specialist, my mentor, Dr. S.C. Arya, wanted to me to get into genetics. So I went and did actually a couple of days in AIMS initially when Dr. I.C. Verma was there and he had not joined Gangaram. And then I came back and said, "It's pretty boring, sir." The reason I said pretty boring was because at that time, even Dr. Verma and Matlika, they were not doing so much of clinical genetics. They had the responsibility of the on their shoulder of getting the test executed. And I thought that the genetists are not able to see the patient clinically, and they are just merely doing the test, behind the screen with no direct connection of the with the patients. So you imagine that was what I thought 3 decades back, that they wouldn't have any connection. But it was so beautiful to see it march. And I truly congratulate the PATS Telangana team now to try to take it to every door, not only of Telangana, but nationally, so that people get to understand that it's not only the tests that we pediatricians should write, maybe it's time that we need to appreciate and develop this branch. The clinical geneticist needs to be highly intelligent, because he needs to be or she needs to be knowing a lot about the symptoms and putting it into the jigsaw. But we are very fortunate with this clinical exome and whole exome. So pediatricians think that, okay, you can do clinical exome and whole exome, and why do we need? But dear friends, to interpret this, it becomes equally important. Like in my specialty, I have to interpret it. So even if there are something of variable significance, you will have to interpret it to the clinical scenario and then do it. So indeed, genetics is not behind, the scene as I thought 2.5 decades back. There is clinical genetics, and these people need to improve their branch and multiply and mushroom much, much more than they are presently, because it is not only the children that we talk about and the newborns that we talk about. Dear friends, it is time to be talking about in the womb. So, clinical genetics can do a lot of work when the mother is pregnant and the things in the womb. With that, I would not take more time and heartily congratulate you all to a wonderful speaker, none other than Nirja, who is now the in charge of Division of Genetics in AIMS, New Delhi. With love to Nirja. Over to Bhaskar.
Thank you, ma'am, for your valuable remarks, and thank you very much for your gracious presence. Truly gracious. And now I request our convener and the backbone of the entire series, Dr. Prajna Ranganath, madam, to conduct this webinar. Over to you, Dr. Prajna, ma'am.
Are my slides visible, sir?
Yes, ma'am.
Right. So I welcome all of you to the 8th session of this webinar series. It's been a wonderful journey so far, and we really have to congratulate the Telangana chapter of IAP for this excellent initiative of making clinical genetics a specialty that, I mean, we all know that pediatricians, as Dr. Neela Mohan Madam also highlighted just now, clinical genetics is something that every pediatrician should be familiar with, should be aware of, and all pediatricians need this basic knowledge of genetics in order to provide meaningful care to their patients, because a lot of pediatric cases have either a genetic disorder or a condition which could have a genetic predisposition or some sort of genetic contribution. So we've had a lot of talks in this webinar series so far, which have covered various aspects of clinical genetics, including the basic concepts, cytogenetics, approach to a dysmorphic child, and molecular genetics. So the past two sessions were on molecular genetics. The one in June was on Sanger sequencing, and the one in July by Dr. Ashwin Dalal was on next generation sequencing. So molecular genetic tests are the ones that we use when we are suspecting a single gene disorder. So basically here we are looking at the sequence of the gene. We are looking at variants at the level of the nucleotides. And we have three main testing modalities available with us when we are talking about molecular genetic tests. So that includes Sanger sequencing, MLPA, and next generation sequencing. Sanger sequencing, which we covered in June, is the conventional method where we do PCR amplification of individual parts of the gene, and then each of these parts is sequenced. And usually we sequence the exons and the flanking intron-exon junctions first, because majority of the mutations in the genes lie in the coding portions of the genes. So sequences are then compared to the reference sequence, and the differences that we identify between the patient sequence and the reference sequence are called variants, or previously referred to as mutations. And sequencing, we get this kind of an output in Sanger sequence chromatogram. You can see these peaks visually, and you can appreciate the difference in the nucleotide visually, as well as by comparing to the reference sequence with alignment tools. Sanger sequencing is suitable when you are looking at small genes, specific mutations, and also when you already know which variant to look for. You can use this technique for doing segregation analysis of the variant, that is, to check that variant in other family members. But when we are talking about large genomes, I mean multiple genes, or the entire exome or the entire genome, Sanger sequencing is not a suitable technology, because you have to amplify those individual parts before we can do sequencing. And even if we were to even if we know that we have to sequence one particular gene, let us say the NF1 gene, it has multiple exons. Now, doing individual amplification of each exon and then sequencing would be quite time consuming and also expensive. So when we are looking at large genes, multiple genes, exome, genome, and so on, we use this massively parallel sequencing strategy, and that is called next generation sequencing. So there are different chemistries which are available for next generation sequencing. The two most commonly used chemistries are the Illumina sequencing technology and the ion torrent sequencing. And there are several different NGS-based testing approaches. You have the multi-gene panel testing, where you do simultaneous sequencing of multiple genes associated with a specific phenotype. For example, you may have a skeletal dysplasia panel, you may have an inborn error of metabolism panel, etc. Then you have something called clinical exome or focused exome or Mendeliome sequencing, where you sequence these coding portions and flanking intron-exon junctions of all the genes which are known to have associated disease phenotypes. So usually this information about genes with associated disease phenotypes is taken from the OMIM database. OMIM stands for Online Mendelian Inheritance in Man. Whole exome sequencing is where you do sequencing of the exons and the flanking intron-exon junctions of all the genes. That is the entire coding portion of the genome. Whole genome sequencing is where you sequence the entire genome. So this is how it compares. In whole genome, you are practically looking at you are like breaking up the entire genome into fragments and then sequencing that. And then you are looking at the reads and identifying where the variants lie. In whole exome, you are looking at only the coding portions, the exons only, and of course the flanking intron-exon junctions. And in targeted panels, you're looking at only the specific genes. So next generation sequencing is suitable, as I said, when you're sequencing large genes, multiple genes, exome and genome. So with that background now, we'll move on to today's topic. And today's topic is on inborn errors of metabolism. So IEMs, as Dr. Bhaskar sir mentioned, are something that every pediatrician should know about because they can have varied presentations. They can present right from the newborn period to childhood, to adolescence, to even adulthood. They can have variable presentations involving practically every system. And it's important to recognize these conditions because although, of course, they're not completely curable, many of them are manageable with specific disease-specific therapies, and you can control the symptoms very well. And in fact, if you diagnose them early, you can actually give the child an almost near normal life because you can keep the symptoms under control and prevent irreversible organ damage. So with that background, I'll now invite our speaker for the day, Dr. Neerja Gupta. We are really delighted and honored to have Dr. Neerja as our speaker today, and we really thank her for sparing her valuable time and agreeing to give this talk today. So Dr. Neerja is professor and faculty in charge of the Division of Genetics, Department of Pediatrics, AIIMS, New Delhi. And she's done her MD Pediatrics and DM Medical Genetics from Sanjay Gandhi PGI Lucknow. She has been the recipient of several awards, and she is one of the most prominent clinical geneticists in the country today. So she's been the recipient of the Dr. I.C. Verma Outstanding Researcher Award in 2024, Dr. I.C. Verma Excellence in Research Award for Young Pediatricians in 2020, also the recipient of the Clinical Genetics Society Fellowship of UK in 2012. She's been nodal officer for the Center of Excellence on Rare Diseases at AIIMS New Delhi under the Ministry of Health and Family Welfare since 2022. Also the coordinator for quality assurance for WHO Birth Defect Surveillance Program across the Southeast Asia region. And she has several other honors to her credit. I mean, the list is practically endless. She's also currently the secretary of the Society of Indian Academy of Medical Genetics from 2024 to 2026. She's also been instrumental in developing the online educational tool GeneTalk for SIMG. And her areas of interest include inherited metabolic disorders, lysosomal storage disorders, newborn screening, genomics of intellectual disabilities, skeletal dysplasia, fetal autopsy, arthrogryposis, dysmorphic syndromes, and reanalyzing exomes. She has 225 publications to her credit. So we are indeed really very honored to have you, Dr. Neerja, here today with us. Thank you so much, and over to you.
Thank you, Dr. Pragnya. At the outset, I would like to thank PATS team Telangana, Dr. Neelam Mohan, the president of IAP, for giving the opportunity to discuss much loved topic on IEM. So in this, is my screen visible?
Not yet, Dr. Asia.
Is it visible?
Yes, now it's visible.
Okay. So I've chosen, so we all know that inborn error of metabolism is, it appears to be quite difficult to start with, because you always think of several metabolic pathways that are involved in these inborn error of metabolism. So for this talk, I have tried to make it simpler, so that the audience is able to learn about IEM's classification in a simplified manner, and so that they are able to understand it and apply it in the clinical practice, to familiarize them with the common presentations for early recognition, as early recognition is the key to good outcome, and use appropriate investigation in diagnosing inborn error of metabolism, and to learn about optimal management through case-based scenarios. So, as already it's already been said that in IEMs, they are kind of rare disorder if we talk of them individually, but the cumulative incidence is quite high. It is around 1 in 4,000. These are generally progressive, and these are often unrecognized because of the variable clinical presentation, which mimic many of the pediatric conditions, and it can involve virtually all any type of organ. So it is not limited to neurological. It can involve liver, cardiac, any organ can be involved, and some of them are amenable to treatment with promising outcome if recognized early. So as Dr. Pragnya said, that age is no bar for IEM, so it can happen right from antenatal period till late adulthood, but all depends upon the level of residual activity of the enzyme. And sometimes people may remain asymptomatic throughout the life because of the milder defects, or because they are not exposed to any necessary stress. Also, these IEMs, they have all types of inheritance, like autosomal recessive, dominant, X-linked, or mitochondrial. And it is important to always draw a pedigree to ascertain the risk of recurrence until we have the confirmatory diagnosis by molecular testing. So you all know that all metabolic pathways involve conversion of A into B. The substrate A is converted to product B with the help of an enzyme. If that enzyme is not there or deficient, then it results in accumulation of substrate, deficiency of the product, and once the substrate gets accumulated, it is metabolized to alternate metabolites, which can also have its own manifestation or toxic effects. So to combat all these things, either we can supply the deficient enzyme in terms of enzyme replacement therapy, or enhance the residual enzyme activity by means of vitamins and cofactor. We can also provide metabolites like by diets or drug, or we can also reduce the substrate accumulation by dietary modification or substrate reduction therapy or chelation therapy. And we can reduce the toxic metabolite by increasing its excretion or decreasing its production. So this is a sunburst chart, which was sort of published by International ICIMD. It is an international classification of inherited metabolic disorder, published in 2020 by Carlos. So which suggests that there are more than 1,400 disorders, which are grouped pathways wise, and there are 24 categories comprising of 124 groups. Obviously, it is very, very difficult to remember all these disorders, but this paper provides, this classification provides improved understanding of the interconnection between various pathways. During the same time, there was another paper by Sodibri et al., who have also given a classification into 3 categories of small molecule, complex molecule, and energy defect, so that this simpler classification is more useful for the clinician for making while they are evaluating the patients with inborn error of metabolism, and so that they are able to classify them into small molecule or accumulation type or complex molecule or energy defects. And as you can see that the small molecules, they are mostly treatable, as highlighted here. Similarly, deficiency, small molecules can have accumulation or the deficiency type, and this is the most treatable type of category. For other category, the treatment may or may not be available and it may be quite expensive. So again, for the audience, this may appear to be a little more complex, but unless you go through the paper on your own. So I have tried to further simplify it in terms of disorders of intoxication or disorders of energy metabolism, and the disorder of complex molecules. Disorders of intoxication and energy metabolism, which we all know that could be amino acidopathies, urea cycle defect, organic acidemias, carbohydrate metabolism disorders, mitochondrial fatty acid oxidation defect. Disorders of complex molecules include lysosomal storage disorder, glycogenosis, peroxisomal Golgi endoplasmic reticulum disorder, cholesterol synthesis defects, and there are certain new IEMs. So to further classify it, to further understand it in a better manner, So small molecules, they are generally have rapid onset of symptoms, and the clinical course is episodic with remissions and relapses. So these small molecule defects, they disturb the metabolism of small diffusible water-soluble molecules and have plasma and the urine metabolic markers. So this is very, very important because this will help us in making a specific diagnosis. So in these small molecule disorders, the physical findings are usually not there. They have overlapping symptoms with the common pediatric conditions. So because they have these plasma and urine markers, so it is possible to make a specific diagnosis by certain parameters, which we will see subsequently. And some of the tests are available easily in the ICU setting or in the emergency. And they respond well to the aggressive supportive therapy, which is easily available in the emergency setting. Whereas large and complex molecules, they disturb the metabolism of complex molecules that are neither water soluble or diffusible. So they have gradual insidious onset of symptoms, and there is a relatively slowly progressive clinical course. But the good part is that they have recognizable phenotype. You see the patient and you are able to make a diagnosis. You have specific assays to make a specific diagnosis. They generally have supportive treatment because the treatment is either very expensive or not available. And lysosomal storage disorder is a good example of this. So there's a common misconception that there are relatively few metabolic diseases and only the few metabolic diseases can be treated. So why one should be worried about the diagnosing these IEMs? So it's kind of misconception because many are treatable if they are recognized early. Rapid diagnosis and early instigation of therapy helps in the treatment of those disorders which are amenable to therapy and is associated with successful outcomes and reduces the morbidity and mortality. For untreatable disorders, it is very, very important to establish the diagnosis so that recurrence risk can be provided to the family for the future pregnancies. So if there is a sick patient without any immediate diagnosis, one should try to store the sample so that diagnosis can be made later. So as I said, that it's not that the treatment is not available for IEMs. So in this pie diagram shows that various types of treatment is available, like nutritional therapy, pharmacological therapy, vitamin and trace element related therapy, organ transplantation, hematopoietic stem cell transplantation, enzyme replacement therapy, and now gene-based therapy, which is now increasingly being available. So this bar diagram shows that across various categories of common, so-called common amongst the rare IEMs, we have treatment for about 70% or 50% of the inborn error of metabolism, which includes vitamin and cofactor metabolism related IEMs, amino acid IEMs, and the complex molecular degradation related IEMs, which includes enzyme replacement therapy. So the second objective is to familiarize with common presentation for early recognition. So we will see that when to suspect an IEM. So we can get clues from history in terms of the course of the disease, whether it is acute, intermittent illness, there is any associated lethargy, coma, or unexplained progressive course, history of sudden unexplained sibling deaths, any E. coli sepsis, muscle weakness, positive family history, or unexplained neonatal deaths, and consanguinity. So this all gives clue towards galactosemia, organic acidemias, fatty acid oxidation defect, urea cycle defect, depending upon the symptomatology. At times, if a lady is carrying a child with LCAT syndromes, she can experience acute fatty liver of pregnancy or HELP syndrome, which is a clue towards the diagnosis. If there is a history of specific food aversions like sweets or high protein, then it points towards the diagnosis of hereditary fructose intolerance or urea cycle defect. So the common presentation for the intoxication and the energy metabolism, it is mainly neurological and can have encephalopathy or seizure. These patients can present with hypoglycemia or cardiac dysfunction or hepatic dysfunction. And all this can occur with or without metabolic abnormalities like hyperammonemia, acidosis, or ketonemia. Whereas disorders of complex molecules, they are usually recognizable phenotypes that we will see subsequently, and they have a dysmorphism which can point towards a diagnosis. The other phases of IEMs include the neurological, as I said, in the acute presentation and the chronic presentation in terms of intellectual disability or behavioral phenotypes, aggressiveness, hyperactivity, like we see in mucopolysaccharidosis type 3, cerebral palsy mimics like phenotype in certain conditions, psychiatric presentation, or they can present with movement disorder or myopathy. They can also have cardiovascular malformations, cardiovascular involvement in terms of cardiomyopathy. There may be skin involvement in terms of ichthyosis or scaly lesions, or they can have liver involvement such as in tyrosinemia, or they can have fetal presentation in terms of non-immune hydrops. So high index of suspicion is a must because of the varied presentation that can present across any age, and because of the emergencies. Because of the emergency presentation for these patients, and after knowing that it is amenable to therapy, it is very much required to have high index of suspicion. Early recognition and appropriate metabolic assessment and therapeutic intervention has potential to reduce the morbidity and mortality. We will see through various case scenarios. And it also helps in counseling for future pregnancies. So what do we get in the typical metabolic examination or while examining a child with inborn error of metabolism? It all depends that what type of inborn error of metabolism we are dealing with. For acute IEMs, it is generally sick-looking babies, may or may not have abnormal movements. They are usually non-dysmorphic. They may have some unusual order, and generally when you are seeing a patient in acute emergency, you may not be able to appreciate that order because you need to store the urine for some time and then try to smell. So for certain conditions, it is the clues are there through skin, hair, musculoskeletal involvement, facial by characteristic facies, and by means of evaluation of various systems. So this is recognizable phenotype, and which may be associated with dysmorphism. And this is largely the complex type of conditions. So the clue to diagnosis is basically through the clinical signs whenever you examine the patient, the clinical course, whether it is acute relapsing with any diurnal variation, it is progressive, static, or it is responsive to triggers, is presence of different types of ocular, characteristic type of ocular findings, or the radiological findings. A combination is often useful for making a diagnosis. So let's see the certain recognizable phenotype, which may be a part of a small molecule disorder or as a complex molecule disorder. For example, this is a patient with intellectual disability, had blonde hair. So straight away the diagnosis of this patient with intellectual disability and blonde hair will be PKU. This was a patient who presented with seizures and had sparse hair. So this is a patient with biotinidase deficiency. So this was a patient who presented with hyperammonemia, and the diagnosis showed arginosuccinylase deficiency, where you can see the hair abnormality in terms of trichorhizis nodosa. And this we all know that the Pillai Totai type of hair is a clue to the diagnosis of Menke-Kinki hair disease. So if you have a dolls-like facies along with hepatomegaly, you have the diagnosis of glycogen storage disorder. Of course, you need to classify them accordingly based upon certain parameters. If you have joint contractures or cataract and X-ray shows stippling, then it is chondrodysplasia punctata. You have short nose filled from a characteristic facies as well. For some of the for paroxysmal disorder, the dysmorphism is present in terms of high forehead, shallow orbits. There is talipus equinovarus, which can present during antenatal period as well. Anteverted nares with mild micrognathia. So they generally have profound hypotonia, may have seizures, hepatomegaly, and the retinopathy. So the flat facies is a clue towards the Zellweger syndrome. So post-facial facies, we all know that we can see it in hypothyroidism, but if this post-facial feature is present with other systemic features such as joint contracture, it points toward mucopolysaccharidosis group of disorders. So these are different patients with mucopolysaccharidosis type 1, which is Hurler phenotype, the coarse, just see the facial coarseness in all these three patients. The level of coarseness is different in all these three, depending upon the type of mucopolysaccharidosis. So here in this child, it doesn't have any facial coarseness, but this was 1S. So in mucolipidosis also you get facial coarseness, but here the phenotype is clearly different from the Hurler phenotype. They can also have craniosynostosis along with these coarse facial features. So presence of Mongolian spot points to, along with organomegaly, it points towards GM1 gangliosidosis or Niemann-Pick disease, can also be seen in Hurler syndrome. Presence of abnormal pad of fat, as you can see here in the posterior suprapelvic region and around the around the genitalia, is suggestive of congenital disorder of glycosylation. It may not be appreciated in all types of CDG, but it is commonly seen in type 1 CDG. And similarly, the inverted nipples may also be present. So it's very, very important to examine the patient thoroughly. So apart from this, other manifestation of skin such as ichthyosis, in the presence of organomegaly, it points towards Gaucher disease. But if it is associated with facial coarseness, joint contracture, hirsutism, then it points towards multiple sulfatase deficiency. If there is presence of painful joint swelling along with nodules with hoarseness of voice and breathing difficulty, it points towards Farber disease. This was one patient where, based upon the history of the previous child, this baby was called for evaluation and it was found to be Farber disease. This was a patient with Fabry disease where many angiokeratomas are seen, and angiokeratomas can also be seen in other conditions like GM1 gangliosidosis, galactosialosis, or fucosidosis or menosidosis. So any of these skin signs, if they are present, then think of a storage disorder. So then joint involvement, as I said, it is seen in mucopolysaccharidosis. You can appreciate the joint restriction and the umbilical hernia. So that's an important clue towards differentiating it from hypothyroidism, congenital hypothyroidism. Also, you can see the small joint contracture and there is inability to make fist, which and you can see the claw hand. In contrast to MPS 1, 2, MPS 7 or MPS 6, the MPS type 4 have joint laxity and they can have a lot of joint deformity and the chest deformity. Presence of gibbus is an early sign for MPS 1. So this baby had gibbus and you can see that it can be very well appreciated. If you do not examine it like this, then you are likely to miss it. Then the kyphosis can also be present because of the spinal involvement in Gaucher disease. So again, a thorough examination is important to make a diagnosis. So if this joint involvement is associated with hepatosplenomegaly and facial coarseness, you know that the diagnosis is mucopolysaccharidosis. And if there is no joint involvement, but only the hepatosplenomegaly present with or without eye manifestation, then it can be classified as Gaucher or Niemann-Pick disease after ruling out any other common pediatric causes. Then the eye evaluation also provides clue, like for example, in Gaucher disease type 3, ophthalmoplegia or oculomotor apraxia is one common sign which is seen. And we know that MPS 1 and MPS 2 can be very well distinguished by presence of coronal clouding in MPS 1 and absence of the same in the MPS 2. And cherry red spot has very few differential diagnoses and is kind of hallmark for Tay-Sachs disease and Niemann-Pick disease. So this was one lady who was referred to us during pregnancy and was labeled as rheumatic heart disease. So sometimes the patients with mucopolysaccharidosis, they are mislabeled as rheumatic heart disease because of the valvular involvement. So you can appreciate that there is joint contractures here, umbilical hernia, and the facial coarseness. So it is important that all rheumatic heart disease, to know that all rheumatic heart disease may not be all valvular disease may not be rheumatic heart disease. You need to evaluate the patient carefully. So this is just a table which is available in most of the textbooks, that these are the key points that one needs to look for whenever we are talking about lysosomal storage disorder, so that one can classify into different categories based upon the clinical evaluation. So then there is another condition which is associated with gross hypotonia. As you can see that floppy, this is a floppy infant. So the diagnosis here is not spinal muscular atrophy because there is presence of cardiomegaly. So there is marked hypotonia with absent reflexes, but because there is cardiac involvement, so this is a characteristic of Pompe disease, and the enzyme is deficient, and enzyme replacement therapy is available for the same. So we get clues from examination, the thorough examination. We also get clues from investigation, and obviously the investigations will depend upon the detailed examination, and it includes either radiological evaluation in terms of skeletal survey for mucopolysaccharidosis group or neuroimaging for neurodegenerative conditions. Sometimes electrophysiological studies are important for metachromatic leukodystrophy or Krabbe disease. Hematological or peripheral smear and certain biomarkers may be of importance. We will see later on. And histopathology, which earlier used to be done very widely for making a diagnosis of Gaucher disease, Niemann-Pick disease, but nowadays, because the enzyme assays are available, so it is not used mostly. Then you can get some clue through urine MPS typing, which type of MPS it is. But I feel that the MPS is basically a clinical diagnosis. You can very well categorize them based upon the clinical evaluation. Then you have oligosaccharide analysis, which is also available in certain labs. But I think the clinical evaluation is a must to make a specific diagnosis and then to order the subsequent testing. So these are certain pictures of dysostosis multiplex. Sorry. Which is a variable degree of proximal pointing. You can see that there is variable degree of proximal pointing and wide expanded short metacarpals and the phalanges, and the cortex are thin. So as we saw that the MPS 1H, 1S, they are all different in the phenotypic presence. So likewise, the skeletal manifestation can also be variable. They can also have, these patients can also have J-shaped sella. As you can see that this is normal and this is the J-shaped sella in patients with mucopolysaccharidosis. Then when looking at spine, they can have inferior beaking or they can have central beaking, inferior beaking in MPS 1 or 2, or central beaking seen in MPS 4. So at times, neuroimaging is quite useful for making a diagnosis after having a careful history and examination. For example, in MLD, you get tigeroid pattern. In Canavan also, you have specific involvement, confluent, bilateral symmetrical, confluent, deep subcortical white matter changes here. And for ALD, it again, the posterior parieto-occipital involvement. So pattern recognition on MRI is very helpful in making a clinical radiological diagnosis. Again, it is all dependent upon your basic clinical examination. So so for example, for MPS, MRI may not be diagnostic. So it requires the clinical examination and then ordering of a specific test. Now coming to the most important tests which are helpful, especially for the intoxication type of metabolism, IEMs. This is known as GLAT, which means measuring glucose, lactate, arterial blood gases, ammonia, and ketones. So if we have all these five parameters information with us, then it is possible to classify them, that which type of inborn error, acute inborn error of metabolism we are dealing with. For example, if there is the presence of hypoglycemia and with mild lactic acidosis, with mild hyperammonemia, it points toward fatty acid oxidation defect. Whereas if there is no such abnormality, then it points towards neurotransmitter disorders or non-ketotic hypoglycemia. So likewise, this wheel is important and can be applied in your day-to-day practice. Apart from this, you have LFT, complete blood count electrolytes, CPK, uric acid, which can also be helpful in making, can be supportive in making a specific diagnosis. So, for example, you will have derangement of LFT, RFT in urea cycle defect. CPK may be raised in fatty acid oxidation defect or like GSDs. Uric acid may be high or low depending upon whether it is molybdenum cofactor deficiency or not. Vitamin B12 and homocysteine are important for cobalamin defects, and lipid profile may also be important in GSD. For metals, you need to have specific tests. If you're suspecting Menkes disease or Wilson disease, you need to do the plasma copper level or ceruloplasmin level. Serum prolactin may be useful because it may be elevated in the dopamine synthesis related neurotransmitter disorders. And similarly, if you're suspecting porphyria, then this urine profibrinogen has to be done. So then you have special test, which is obtained on the dried blood spot, and you can see that taking appropriate sample is important so that you can measure the abnormal amounts of normal metabolites or abnormal metabolites or both. If the sample is correct, then it is easy to measure it correctly. And it is done by acyl carnitine analysis by MSMS, amino acid analysis by HPLC or LCMSMS, organic acid analysis of urine sample by GCMS. One can do plasmalogen evaluation as well. Sometimes CSF amino acids are also required to be done, for example, in non-ketotic hyperglycemia. And you need to do the enzyme assay or on either leukocyte or skin fibroblast, depending upon the type of condition that you are dealing with. But at the end of it, we need to have a DNA-based diagnosis so that a specific diagnosis is made and the family can be held in the subsequent pregnancies. So this is a broad chart which is used, making use of this wheel and is able to classify into different types of small molecule condition. And so here you can see that in presence of acidosis or no acidosis and presence of other parameters can help you in classifying it into specific conditions. And you require this special test to confirm for a confirmatory biochemical diagnosis. And this has to be followed by a DNA-based diagnosis. So coming about to the third part, that is learning about optimal management. So here I will use some case scenarios where we'll be like sort of solving those case scenarios. So first I'll deal with some of the acute presentation. So this was a baby who was 6-day-old female, second born to non-consanguineous couple. There was no family history, but the baby had lethargic, poor feeding and seizures since day 3 of life. Examination showed presence of hypothermia, reduced tone with loss of reflexes. Sepsis screen was normal, as we all know that with this we will all suspect sepsis. And the blood culture report was not available. And meanwhile, GLAC was done and it showed high ammonia level. Rest all the parameters were normal. So with this high ammonia, you will think of only one condition. We will see subsequently. So this was acute encephalopathy with hyperammonemia. So ammonia, a word about ammonia, that the level of ammonia is important and the age is important at which we are trying to interpret. So it is generally taken in EDTA vial and it is transported immediately on ice. So depending upon the age criteria, the level of ammonia is taken care of. And in this child, it was 1000 was high, so it was suspected to have your urea cycle defect, and the TMS showed increased citrulline. So with increased citrulline and hyperammonemia, it was likely that it is probably citrullinemia. But the GCMS also showed elevated orotic acid. So if we look into this particular graph, in the presence of hyperammonemia without acidosis, it is important to do the amino acid analysis, which can be done by LCMS-MS. And if you look for the specific amino acid elevation, like here in this, citrulline was high. So, so it confirms that it was citrullinemia. So then once you have a child with who is coming to the emergency with and is lethargic, then after having this bedside investigation of blood gas and ammonia, it is possible to narrow down it to specific diagnosis. So then after ensuring basic life function, one should try to treat the precipitating factors, including sepsis, because presence of sepsis also precipitate a catabolic state. So it is important to recognize sepsis and treat it simultaneously. And the if the IM is think about and one should try to think simultaneously about an IEM. So that is why during that critical period should also obtain the sample for essential testing such as ammonia, and keep the ADTA blood, dried blood spot, and urine, so that all these critical samples are taken, which are critical for making a diagnosis of IM. So while the reports are awaited, the special tests are awaited. So based upon the ABG lactate or GLAC, one can make a tentative provisional diagnosis. Then one can try to provide sufficient energy supply and stop protein intake. This is done to stop the catabolic state and improve the anabolic state. Steps are taken to prevent the accumulation of toxic metabolites. The acid-base balance is corrected, and the supportive therapies are introduced. For example, if there is sepsis, then the infection is treated. Seizures, then the anti-seizure medications are given. For hyperammonemia, sodium benzoate, sodium phenyl acetate, or arginine are given. Sodium benzoate oral formulation is available. Nowadays, sodium phenyl butyrate is also available orally in India. Arginine is also available orally in India. But if there is rapidly increasing hyperammonemia with ammonia value exceeding 400, 500, then one should go for hemodialysis. Peritoneal dialysis and the exchange transfusion are less effective. So in this patient, after making a diagnosis of citrullinemia, specific Sanger sequencing was done for ASSS1 gene, and it showed homozygous mutation in this particular gene. So this enabled us to make do the prenatal diagnosis in the subsequent pregnancy. Now this child is quite old. This child is now 8 years old. This is an older slide and is doing quite well. So this is another case where the baby was symptomatic from day 3 of life, had lethargy, vomiting, hypotonia, and seizure. Examination just had sick-looking baby. So again, suspected as sepsis or IEM. And then GLAC was done, and it showed high lactate, acidosis, mild hyperammonemia, and the ketones were positive. So this was acute encephalopathy with high anion gap metabolic acidosis, and this was born to a non-consanguineous marriage without any positive family history. So if you examine this flow chart again, there is presence of elevated lactate, there is ketonuria, there is hyperammonemia, there was no hypoglycemia in this particular case, but they may have hypoglycemia. And then it all points towards organic acidemia. So here also the possibility of organic acidemia was kept. And the general principles, as mentioned earlier, are followed. One need to prevent catabolism by providing adequate calories and fluid intravenously. And then in case of, because you are providing 10% glucose at 150 mils per kg per day, to provide 10 to 15 milligram per kg per minute of glucose. So they may have a hyperglycemia also. So insulin is also given to prevent the catabolism, and we all know that insulin is an anabolic hormone, so it is at times it is useful. So then the protein is reintroduced into diet gradually over next few days, because we do not need to restrict protein too much. So because it is important for the baby's growth, and one should not keep the child into a catabolic state for a very long time. So then the facilitation of excretion of toxic metabolite is done by means of L-carnitine for organic acidemias. If baby is sick, then it is given intravenously, and later on it can be given orally. For isovaleric acidemia, glycine is given, And dialysis is considered if there is persistent metabolic acidosis, which is not improving to the therapy. If there is hyperammonemia, then sodium benzoate or arginine is given. For organic acidemia, especially particularly for propionic acidemia, oral metronidazole is given because we want to eradicate the propionic acid producing gut flora. And the megavitamin therapy is also given. One should try to avoid anti-epileptics that inhibit the mitochondrial function, such as valproate or chloral hydrate. So in this case, the TMS showed elevated C3, propionyl carnitine was high, GCMS was also abnormal and suggestive of methylmalonic aciduria. The exome sequencing showed presence of methylmalonic aciduria homozygous variant, pathogenic variant in this particular gene. And the patient was continued on oral carnitine supplementation, hydroxycobalamin injections, MMA-specific diet, sodium benzoate, and was discharged on day 90. However, this though this child was on long-term management, but this child continued to have these acute metabolic crises every now and then. So you can see that these metabolic crisis episodes, they continue to increase over a period of next 2 years. So the patient was given an option of liver transplant, which was done subsequently on 13th of this year. And you can see that there was a decline in the C3, C2 level and the methylmalonic acid levels subsequently. MMA levels almost normalized by day 10 of transplant. And the sodium benzoate and the arginine were also tapered off because there was no hyperammonemia. So now the baby is on MMA-specific diet, oral carnitine, and injection hydroxycobalamin weekly and is doing well. So there is no crisis for last 6 months. So earlier, every month he used to get admitted. So coming to another case, this was a term neonate, day 7 of life, had lethargy, apnea, seizure, managed initially at a remote hospital telephonically. So this was a telephonic management because the patient lived far away. So the initial investigation showed done at that place only showed high in iron gap metabolic acidosis, hypoglycemia, hypocalcemia, hyperammonemia, and pancytopenia. So with the suspicion of organic acidemia, the expectant management was started. The metabolic screening showed elevated C3, and again urine GCMS showed elevated methylmalonic acidemia. However, because this was a possibility of organic acidemia was kept, and so therefore these patients we generally start hydroxycobalamin as mentioned earlier. So the repeat GCMS was done after some time, and it showed normalization of methylmalonic acid levels, suggesting that it was vitamin B12 responsive. And by that time, the exome sequencing report showed MMA type of pathogenic variant in homozygous pathogenic variant in MMA gene. So this was the child who is now 1 year old and on dietary and the medical management and is doing well. So I showed these two case scenarios just to highlight that they can have varied type of manifestation and can have various different outcome based upon the type of management and based upon the type of gene. So they can be very severe and they can still they can do very good without any liver transplantation. On the other hand, depending upon the gene involved, the presentation can be very severe and might require liver transplant for frequent decompensation. So for any organic acidemia and any neonate, for organic acidemia and any neonate with encephalopathy and with high iron gap metabolic acidosis and hyperammonemia, one organic acidemia should be suspected, and one should try to give a B12 because early B12 responsiveness can be life-saving for these children. Coming to the next case, this was a 2-week-old baby who had poor feeding, vomiting for 3 days, tonic seizures for 1 day, had abnormal sucking and cycling movement, intermittent opistosonic posturing. And here the ketones were positive, DNPH was positive. There was lactate was 2.2 and rest of the tests were normal. So this was acute encephalopathy with ketosis. So we know that in newborns, the presence of ketosis in newborns is suggestive of organic acidemia, because the newborns, they have beta hydroxybutyrate is the predominant ketone, whereas if urine ketostics are positive, then it suggests that it is acetone and acetoacetate, so which is very suggestive of organic acidemia. So one should always suspect organic acidemia if there is massive ketonuria. And if there is presence of hypoglycemia with absent ketones, then the differential diagnosis is fatty acid oxidation defect. So in this case, the TMS showed high levels of leucine, isoleucine, and valine. And GCMS was also suggestive of maple syrup urine disease. So the child was put on carnitine supplementation, dietary management, and restriction of branch chain amino acid. And was put on long-term dietary management, which is useful for various other conditions like organic acidemia, glycogen storage disorder, and amino acidopathies and urea cycle defect. So in this case, long-term management is an integral part of these patients with inborn error of metabolism, because this dietary manipulation, adjustments, etc., is required based upon the weight. Growth monitoring is very important. Target organ monitoring is very important, and the treatment of decompensation is also very important. And this all is possible if the long-term dietary management is in place. And it is important for the family to do the lifestyle adjustment, because these patients, they require special food which is procured either locally or imported. So you need dedicated patient, because as these patients grow, they tend to avoid such feeds. Dedicated family and the metabolic dietitian and the metabolic physician, because these patients require monitoring very often. So in this particular case, again, like in the previous case, there was frequent decompensation. This patient required peritoneal dialysis. It was a stromy course in first few months, and subsequently there was frequent admission because of decompensation. So MSUD, I feel, is the most difficult condition IEM to manage, because you require a lot of dietary control and a lot of abnormality of amino acid takes place. So subsequently, because there was a recurrent decompensation, the option of liver transplant was given to the patient, and liver transplant was done around 9 months of age, and this patient is not now doing well. So coming to another presentation, that is seizures at day 2 of life. So this snapshot of the medical records is just pasted here to highlight that if the records are captured in a good manner, then we know that what is going to be the diagnosis. So in this case, it was a routine protocol of neonatal seizure was followed. There was no hypoglycemia, hypocalcemia. The anti-epileptic drugs were not useful for this baby, and the pyridoxine was given, and the baby responded to pyridoxine, and which was continued. So by the time the management was done and the rapid exome was sent, so it showed a presence of variant, likely pathogenic homozygous variant in this particular gene, which is a pyridoxine responsive gene. So now the patient is doing well, 6 months old, and is absolutely normal. So pyridoxine responsive seizure is one of the treatable cause of catastrophic neonatal seizures. So one should try to follow the protocol if the neonatal seizures are uncontrolled after first, second lines of anti-epileptic drug. So these are certain metabolic conditions where this cofactor therapy may be useful, like for maple syrup urine disease, thiamine, methylmalonic acidemia, vitamin B12, as I mentioned earlier. For biotinidase deficiency, biotin is required, GA1, riboflavin, pyridoxine responsive seizure, pyridoxine. So majority of these small molecule IEM require such vitamin therapies. So now this is another condition where this patient was had onset at 13 months of age with progressive abdominal distension and intermittent vomiting. There was mild motor delay, no seizure. He was absolutely cognitively normal. At 2 years, again, there was acute episode with vomiting, and this time he had hypoglycemia and hepatomegaly was noted. So metabolic screen showed presence of high lactate, hypertriglyceridemia, and there was urinary ketones were positive. GCMS showed presence of glycerol-related metabolites, and the diagnosis was clear that it is fructose 1,6 bisphosphate deficiency. So based upon which targeted Sanger sequencing was done, and the mutation was found. So for fructose 1,6 bisphosphatase, the management is very simple. One should avoid fasting. Frequent feeds are given with complex carbohydrates, and one should follow the sick day protocol. The danger signs are explained to the family, and giving just IV fluid can restore the metabolic abnormalities. So this is another child who was at 1 year of age and had a febrile illness at 10 months of age with loss of acquired milestones, became floppy, poor head control, feeding difficulties, reduced activity, and developed seizure. Examination showed presence of central hypotonia without any dysmorphism or organomegaly. So again, the metabolic screen was all entirely normal except the high lactate, and the MRI showed presence of cystic encephalomalacia with significant corpus callosum involvement, and it was suggestive of mitochondrial complex 1-2 deficiency. So the exome sequencing was done, which again confirmed the finding, and it was a homozygous likely pathogenic variant in this particular gene. So this was another case. This was a lady who presented, who was a gravida 6 lady who presented at 14 weeks of gestation. And when the detailed history was taken, then it was found that there was a respiratory distress in the previous children. There was a respiratory distress at 1 year of life and required mechanical ventilation. There was no symptom-free interval in this particular baby. There were no seizure. There was hypotonia. Baby was kept in nursery for about 2.5 months. There was a positive family history of 2 similarly affected babies who died at the age of 5 days and 24 hours of life. So it was a quite stormy presentation. And there were limited records were available except for this MRS, which showed a lactate peak, and there was records which showed persistent metabolic acidosis with elevated lactate. So this was around 12-15 years ago when this patient was seen. So possibility of so there was persistent metabolic acidosis with elevated lactate. TMS was done, which showed elevated level of citrulline. And GCMS also showed metabolites that were suggestive of ketosis and lactic acidosis. So based upon this, possibility of pyruvate carboxylase deficiency was kept, because we know that the mildly elevated citrulline may be seen in PC deficiency. So fortunately, the DNA of the previous affected child was saved, and it was subjected to the direct sequencing based upon the biochemical result of TMS and GCMS, because 15 years ago there was no exome sequencing, and baby was found to have this homozygous variant in this particular gene. So this was the pedigree in where you can see that there were 2 children who were affected, and this was the baby from where the DNA was available. These were all not available. They also died early. So the take-home message from these last 2 cases is that the regression after a simple febrile illness should raise a concern for any intoxication or the mitochondrial disease. Elevated lactate with normal TMS, GCMS is a critical clue for mitochondrial disease, like we saw in complex 1-2 deficiency. MRI or MRS brain may give a clue, and largely the management for such disorders may be supportive. So triggers can precipitate, like hypoglycemia, fasting, or fever, or sepsis, can precipitate metabolic crisis and may cause irreversible damage. So one should try to avoid triggers. So coming to the chronic presentation, so this was a baby who had abdominal distension, 1.5-year-old baby who had abdominal distension at 2 months with poor weight gain. There was no history of jaundice, bleeding, or neuroregression. We can see that there was hepatosplenomegaly. Development was also normal, and examination showed presence of just hepatosplenomegaly. Lab parameters showed high alpha fetoprotein, and there was no coagulopathy or other abnormality. So presence of normal cognition, hepatosplenomegaly, high AFP, one would think of tyrosinemia, and that's why the TMS and succinyl acetone was done, and which was suggestive of tyrosinemia, and there was a homozygous variant in this particular gene. So why it is important to know? Because now for hereditary tyrosinemia type 1, the medicine is available, it is made in India, and it is possible that these patients can live a normal life once they are diagnosed early and the treatment is initiated in a timely manner. So in any child with unexplained hepatomegaly with elevated AFP, always check succinyl acetone, because this is the most sensitive specific marker for tyrosinemia type 1. So another case, which was a 1-year-old female with mild motor delay, had episodes of lethargy. There was no overt hypoglycemia or encephalopathy. Liver was just 2 centimeter below right costal margin. Echo was done and it showed severe LV dysfunction, global LV dyskinesia, hypokinesia with mild MI. So if you look into the pedigree, there was a history of one SIP death at 12 years of age with dilated cardiomyopathy. She was symptomatic since the age of 4 years and had ejection fraction of 15 to 20%. And it was presumed that it was a post-infective myocarditis and the patient was managed like that. But unfortunately, the baby died during COVID because of the LRTI. So in this baby, so we did not have any sample or anything from this previous child. So for this baby, based upon the history, metabolic screening was done and it was shown that the carnitine levels were low. And the exome sequencing revealed that it is a systemic carnitine deficiency, which is a treatable disorder. So it was compound heterozygous for these two variants, which was segregating with the parents, and the patient was instantly started on oral L-carnitine. So this is one of the simple disorder, treatable disorder, easily treatable disorder. So child with dilated cardiomyopathy, one should always check carnitine levels and initiate the treatment. So another spectrum of IEM is involvement of skin that I mentioned earlier. So this was a pedigree. Here there were 2 children affected. So both children had both had ichthyosis and developmental delay. So and along with that, both had joint contractures. They had failure to thrive. There were seizures. There were developmental delay. MRI showed delayed myelination and diffuse cerebellar atrophy. There was diffuse corneal opacity and the hair were easily pluckable. So we thought that it is probably a dual kind of phenotype because it was not fitting into anything. And there was no abnormal fat distribution, etc. However, exome sequencing showed presence of a VUS variant for this particular disorder of congenital disorder of glycosylation. And because it was VUS, so we were again unsure that whether it is suggestive or not. So that is why transferrin isoform analysis was done, which showed mild increase in the dicyclotransferrin. So any child who is having ichthyosis, one should examine again thoroughly so that if there is involvement of neurological involvement, then one should remember Jorgen-Larson syndrome and multiple sulfatase deficiency along with congenital disorder of glycosylation. So sometimes one can have stroke-like episodes as it is seen in conditions like homocystinuria, MELAS, congenital disorder of glycosylation, Fabry disease, maple syrup urine disease, respiratory chain defect, and urea cycle defect. So if there is any stroke-like episode, one should rule out metabolic condition. And so this was one child who presented with global developmental delay, had at 4 months had one brief episode of seizure with post-ictal drowsiness. At 4 years, again episode of focal seizure with limb tightening. At 11 years, after a diarrheal illness, developed weakness and the spasticity of bilateral lower limbs. So he presented to us at 11 years of age in altered sensorium and seizure. MRI showed diffuse cerebral and cerebellar atrophy. And as a part of the protocol, we did vitamin B12 and homocysteine, etc. And you saw that the homocysteine levels were highly elevated. So we thought of MTHFR deficiency and initiated the specific treatment in terms of beta and folinic acid, etc. And the exome also confirmed the finding by showing a pathogenic variant, homozygous pathogenic variant in MTHFR gene. So message here is that the homocysteine is a frequently missed metabolite that is analyzed for such metabolic patients. So one should try to test homocysteine levels for any child who presents with neurological involvement, especially the developmental delay, spasticity, and seizure. because if we recognize them early, so then we can probably delay the diagnostic, we can avoid the diagnostic delay which happened in this particular case. So then some patients can present with developmental delay, regression and encephalopathy. This could be a this could be a presentation of an attenuated type of non-ketotic hyperglycemia, wherein you need to measure the CSF glycine levels along with plasma glycine level. Why am I stressing this? Because we know that we are living in the era of NGS and we tend to send NGS. But many a times, like I showed in previous one slide of CDG, that VUS needs to be characterized, whether it is can be converted into likely pathogenic or not, and that is possible only by the metabolic testing. So that is why it is important to do the testing, and in this case also the variant was found in the NKH1 gene. So another important point to remember is that the TMS and the GCMS is normal in CDG, in NKH. Sorry. So this is another patient who had who was a 2.5-year-old boy with smooth perinatal transition, had global developmental delay, central hypotonia, but along with dystonia. There was no seizure or regression of milestone. MRI showed characteristic widening of Sylvian Fisher, which is characteristic of glutaric aciduria type 1. So, and this child also had large head. So, large head, widening of Sylvian Fisher, and there is developmental delay or dystonia. So, it suggests that there is a possibility of GA1, and the TMS also showed increased C5DC, and urine GCMS also confirmed the same. So, this showed a likely pathogenic homozygous variant in the GCDH gene. So, here we know that the treatment is specific. You need to restrict lysine and tryptophan, and need to supplement carnitine. So it is important to recognize such condition, because if you avoid that trigger, then it can avoid that striatal necrosis and the dystonia. So one has to be very vigilant for these patients. And early diagnosis and can help in preventing this irreversible dystonia. So this is probably the last case. So this was a case who presented at 1.5 years of age with had smooth perinatal transition. There was no birth asphyxia, but the head circumference was minus 7.1. There was spastic paraplegia, axial hypotonia, and there were seizures which were controlled on levetiracetam, and there were poor visual tracking. And the MRI showed presence of microcephaly, simplified gyral pattern, and there was diffuse cerebral atrophy with thinning of corpus callosum. So here the TMS GCMS was done, which was normal. However, examination exome sequencing showed presence of a homozygous variant in arginase asparagine synthesis deficiency, which is a cause of microcephaly. So apart from this, we can see such presentation, which is progressive spastic paraplegia microcephaly, could be mislabeled as CP, especially for such condition, and other conditions like sulfite oxidase deficiency or molybdenum cofactor deficiency. So GA1, so spastic, so dystonic CP or spastic CP can be a mimic of a metabolic condition. So in the presence of smooth perinatal transition, in the presence of consanguinity or positive family history, if there are progressive or worsening neurological signs, or severe or acquired microcephaly, or there is atypical or unexpected MRI finding, one should rule out genetic or the metabolic causes, which could be a masquerader of CP. So sometimes we get good clues from antenatal history. For example, if there is non-immune hydrops, so we know that there is a big list of conditions, metabolic condition, which can be which should be looked for if there is an antenatal manifestation of non-immune hydrops. So, in this particular case, which manifested antenatally in terms of echogenic kidney, and there was a positive family history where the second child had postnatal acute renal failure with metabolic acidosis. Metabolic workup was done, and it showed high level of carnitines. Newborn autopsy was done. It showed multiple nodules in both the kidneys with two simple cysts in right kidneys. So here the DNA samples were saved. This was again 15 years ago. This case had come. 10 years, 12 years ago, this case had come, and at that time, exome sequencing was not done, but the DNA sample was saved. So then subsequently, because the lady came during pregnancy, so exome sequencing was done, and it showed presence of a pathogenic variant in the CPT2 So there are several causes of metabolic causes of ecogenic kidneys, like glutaric aciduria type 2, neonatal form of type CPT2, or Zellweger syndrome, or Smith-Lemli-Opitz syndrome. So one should evaluate in a good manner once we see the ecogenic kidney. It's not always ARP-kidney. So in this case, the final diagnosis was neonatal form of CPT2 deficiency. So this is this is one patient who was saved by newborn screening, because we know that many of the IEMs are treatable, so it is worthwhile to do newborn screening for such conditions. For example, this baby was screened at our hospital during newborn period, but unfortunately, he had symptoms in terms of alopecia at day 7 of life. There was no seizure, nothing. And by that time, we got the newborn screening results as well, and patient was put on biotinidase enzyme, biotin therapy, after confirming the diagnosis on biotinidase enzyme activity and the molecular testing. So now the child is doing well. Now at present, the child is 1 year of age and is doing well. So to conclude, one should try to make a specific diagnosis as much as possible clinically. Utilize these basic screening tests which are available, especially for the acute metabolic condition. Perform special tests wherever necessary based upon your history and the clinical examination. And then also follow the general treatment measure, emergency measures, because we know that the acute intoxication will not have any specific symptomatology, but we need to keep high index of suspicion so that we can treat in a timely manner and initiate specific therapy in terms of excretion and maintaining the anabolic state. And then one should refer the patient for to the specialized center for specialized treatment. For example, for 2 of our patients, we required liver transplantation and it's not available with us. So we refer to some other hospitals for conducting the liver transplantation, and the babies are doing well. So the takeaways are that IEM are rare, but they are treatable. I will not say that they are not treatable. We should never miss a treatable IEM. They are not uncommon. You can age is no bar, and any medical specialty is no bar, because you can through various illustrative cases I have tried to show you that from skin till heart till brain, anything can be involved. From antenatal, from fetus till adulthood, any age can be involved. It can mimic common non-metabolic conditions, so one should consider IEM simultaneously, not as a second test. Simple bedside tests are available in every hospital. This GLAC is available. It is very important to do it as a point of care test and while keeping IEMs in mind. Some of them are very responsive to fluids, so it is very, very important to have these bedside tests. Early diagnosis and correct treatment avoids unnecessary morbidity and even death. One should try to save DNA, because this is we all know now that it is very, very important to save the DNA and make a specific diagnosis by using exome sequencing. And deep phenotyping is very important. This deep phenotyping in IEMs involves biochemical phenotyping as well, which is possible by doing certain specific tests or just obtaining saving the sample for later analysis, for example, plasma or CSF or bright red spot. Then it is possible to do the metabolic manipulations using diet, drugs, and the combination is now very widely available in India as well. And we also have enzyme replacement therapy for complex molecule disease. Dietary management in the long-term management is a key factor for small molecules or intoxication type of metabolic disorder. And one should never forget the preventive aspects, which means that the prenatal diagnosis in the subsequent pregnancy. So I would like to acknowledge patients and families, fellows in genetics, and the multidisciplinary team that we have at our hospital, without which the care of these babies are not possible. So we need to probably think in a metabolic way, because if we don't think, you won't look. If you don't look, you won't find. And if you don't find, you cannot treat an IM. Thank you.
Thank you so much, Dr. Nirja, for that excellent talk. You've given us a very, very good overview of inborn errors of metabolism, and you've shown us some very insightful, illustrative clinical scenarios, which have highlighted all the important aspects of how and when to suspect IEMs, how to diagnose them, and how to manage them. So that was really, really informative. And thank you so much once again for sparing your time and giving this talk. And I think we can move on quickly to the questions. Before we move on to the questions, would you like to quickly tell us about the national policy for rare diseases, under which we are now able to provide treatments for some of these inborn errors of metabolism, especially the little more expensive ones?
Yeah, so we are lucky to have this national policy on rare diseases, because this has opened the ways for various patients, especially for for metabolic patients, because they can get benefit through group 1 category, which involves one-time treatment in terms of hematopoietic stem cell transplantation, which is possible, hematopoietic stem cell transplantation or liver transplantation or renal transplantation, which is important, as I said, for MSUD, MMA, liver transplantation, HSCT for mucopolysaccharidosis. Then similarly for group 2 and group 2, we have for group 1 and group 2, we have a cap of 50 lakhs. Even for group 1, 2, and 3. So there are 3 categories. So group 1, 2, and 3 all have a cap of 50 lakhs, and which is a amount which is given for treating one single patient in a family. And this one-time treatment is more useful for them, because it takes care of all the expenses. For group 2, it is the treatment which is required in a recurrent manner. For example, for tyrosinemia, it requires medicine in a recurrent manner, and it's a lifelong treatment. So till the time this 50 lakhs will end, so patient will get benefit of getting the treatment, and which will largely last for 5 to 6 years, depending upon the age and weight of the child. Then we have group 3, which is the most difficult type of condition group to treat, because 50 lakhs is just a drop in ocean, and they require treatment for lifelong. So if these babies are able to get treatment for around, for example, for lysosomal storage disorder for about 2 years or so, then we are likely to see some improvement and get benefit of this therapy. But if the therapy is lasting only for 6 months in this, out of this 50 lakhs, then it may not be useful. So it's a good step by government, which is benefiting a lot of patients.
Thank you, Dr. Nirja. We'll quickly take the questions. So there are some questions from Dr. Akhil. He's asked, how do you approach a child with pectus carinatum who is otherwise healthy?
So first, don't forget pediatrics.
Okay.
So pectus carinatum can be a manifestation of very many conditions. For example, nutritionally, we need to check whether there is vitamin D deficiency or not. So just solely pectus carinatum, you need to see whether there is any vertebral abnormality or any chest rib abnormality or not, because if there is a rib cage involvement along with sternum, then also there may be pectus carinatum. So after excluding that nutritional causes, look for any bony causes if it is just in isolation. But if it is a part of any other condition like I showed, then you need to evaluate accordingly.
Also, there's a case scenario where he is asked about a child who missed breakfast and then had excessive cry, abnormal behavior, and abnormal movements. And then there was documented hypoglycemia, sugar of 30, there was metabolic acidosis with anion gap of 19. So I think subsequently this baby. So that is probably a different scenario, I think, 3-year-old child. So I think you have shown us a similar case scenario, but
Yeah.
what would be the likely diagnosis in such a case? What should we be suspecting in such a case?
So it could be fructose 1,6 bisphosphatase deficiency as well, because the baby was totally normal. There is I mean, uh, there is a trigger that there was fasting, and it happened. It was followed by metabolic acidosis. You have not mentioned about the course when IV fluid were given, whether he recovered or not recovered. If he recovered, then it is most likely fructose 1,6 bisphosphatase deficiency. You need to do TMS and GCMS to get a confirmatory diagnosis and manage follow the general principles of management.
Is also shown, given another case scenario of 11-month-old child who had 1 day of respiratory distress, intubated outside, echo revealed ejection fraction of around 20%, and then dilated cardiomyopathy was documented with severe LV dysfunction. TMS has revealed query mildly raised glycine, and whole exome has been sent. But again, what IEMs can we think of in this scenario?
So carnitine deficiency, you need to think that needs to be kept in mind. But cardiac manifestation can be there in several fatty acid oxidation defect. It's a male child or female child?
That's not mentioned.
So Barth syndrome can also be one condition where you can have cardiomyopathy. So again, you need to do the TMS. Mildly raised glycine can be there. It cannot be non-ketotic hyperglycemia. You do not see liver dysfunction. So I think you should do TMS, GCMS. Whole exome sequencing is sent. That is okay. But don't forget one omic for another omic. Do genomic, but do not forget about metabolomic. Because if you get VUS, then how are you going to manage? If the child succumb, then you will not get the child again, and your VUS will remain VUS.
Also, he's asked about the dose of thiamine. So, do you give it intravenously or orally, and what's the dose?
Thiamine oral dose is 10 to 15 milligram per day. IV we have not used, but the oral is 10 to 15.
And a question from Dr. Smriti. So, can you share your experience on cerebral folate deficiency and autism?
No, I have not seen. I have heard about it, cerebral folate deficiency, but personally, I have not seen any case with cerebral folate deficiency.
Okay, I think we'll conclude the session with this. Over to Dr. Bhaskar sir for any concluding remarks from your side. And once again, I'd like to thank Dr. Neerja for this excellent and comprehensive overview of inborn errors of metabolism.
I would just like to say one thing, that it was very difficult to cover. IAM is a very vast topic. I just thought that I should touch the essential points, so it went on.
It was very, very helpful. Thank you so much.
Yeah. Thank you, Dr. Neerja madam, for presenting probably a tough topic for pediatricians. But it's very simple, understandable, and it was really useful. And we became more wisdom as far as IEMs are concerned. So thank you very much for your precious time. You spent 1 hour 30 minutes continuously speaking about the topic. It shows your passion and patience. Thank you, ma'am. And thank you, Dr. Prajna, ma'am. Simple thanks
Thank
are
you,
not
sir.
enough for you, but I have no other words. Thank you very much. And
Thank
I
you,
thank all the participants for actively participating in this webinar. So see you all on first Sunday of September with the 9th episode. Thank you. Namaskar.
Thank you.
Thank you, sir.
Thank you.
Thank you, Dr. Neerja. Bye.
Thanks, everyone. Closing the meeting.
Thank you.
Thank you, RSV.
Thank you, sir. Good day.
Thank you. I hope we can see it on YouTube.
Yeah, it's already live.